Now, infectious disorders of viral hepatitis, basically viral hepatitis is infection of the liver, and it's caused by a group of viruses which has an affinity for the liver. These are known as hepatotropic viruses. But there are other viral infections which can also cause hepatitis, that is Epstein-Barr virus, IM is infectious mononucleosis, cytomegalovirus, yellow fever, all these can also cause hepatitis, but most commonly, most of the hepatitis is caused by the hepatotropic viruses. So this table, you can go through it. It's a very compact table of hepatitis, the types of hepatitis, A, B, C, D, E. What you have to notice here is the difference. All of them are single-stranded RNA. Hepatitis B is the only one which is double-stranded DNA. The transmission A and E is fecal-oral, but B, C, D are parenteral, that means through IV, through the blood, and also it may be due to close contact. The incubation period here, the hepatitis A virus has the shortest incubation period. It's always an acute history, whereas the others have a longer incubation period. Notice here that hepatitis D virus has the same incubation period as hepatitis B virus. Okay. A carrier state, hepatitis A gets cleared completely, and hepatitis E don't know yet. But these B, C, D are dangerous because they do have a carrier state. The ability to go into chronicity, hepatitis A, because it clears completely, obviously there will be no chronicity. But hepatitis B, 10% of acute infections. C is very, very dangerous. 80% of cases can go into chronicity. Hepatitis B, remember this one, when I talk to you, you'll know that hepatitis B cannot infect anybody on its own. It needs the help of hepatitis B. So generally it follows the hepatitis B chronicity, but if hepatitis B is there with D, then the chronicity becomes much, much higher. Okay? Hepatocellular carcinoma, B and C can cause hepatocellular carcinoma, and these are unknown. The diagnosis, we'll go through that in the main slides. So hepatitis E virus, you may get this as a question, analytical question, which is similar to what I have already given you. And remember, hepatitis A virus, the history is always a very short acute history, and the clinical symptoms will always have loss of appetite, nausea, and fever. These are the main things, jaundice also. Okay? Or they may ask you, what other things might be there, you have to say jaundice. Okay, so short history, and usually they may give a history that the patient was traveling, he was eating in new kind of places, because this is it's a fecal-oral route. Okay, so that's a clue that it's a fecal-oral, and the acute presentation, and mainly the loss of appetite, nausea, and fever with jaundice. Okay, so these are the main things. What I want you to notice here is also that HAV, even though it's a very self-limited benign disease, but 1% can go into fulminant hepatitis. This is something which you have to remember, because even though it looks like it's a very benign self-limited, but 1% may go into fulminant hepatitis, and fulminant hepatitis usually is lethal and patient might die. So this is the way, the diagnosis. Vaccine is there, it's effective. People who come to India always receive hepatitis A vaccine. Hepatitis B virus can produce so many things. There can be just acute hepatitis with resolution like hepatitis A, or it may be a non-progressive chronic hepatitis. This is if the person is lucky, this happens. But the not so lucky ones will have a progressive chronic hepatitis, and this progression can lead on to cirrhosis. Okay, and once cirrhosis sets in, it's absolutely irreversible. You cannot save the liver anymore. The only way you can save is by having a liver transplantation. Then fulminant hepatitis can also happen. Fulminant hepatitis means that the liver will undergo massive liver necrosis, and it is absolutely an acute situation in which it's usually lethal. And hepatitis B can vary in its pathogenicity depending on its relation with hepatitis D virus. Or hepatitis B may be absolutely asymptomatic, but it may have a carrier state. Okay. So, chronic hepatitis represents carriers of actively replicating virus, which is a source of infection, and HBV also can cause hepatocellular carcinoma. So, these are the clinical outcomes of acute hepatitis B virus. This can come as a question again. The clinical outcomes or the clinical progression of hepatitis B virus. These are the kind of questions which can come as short notes, in which you have to know the flow chart like this, that acute hepatitis B, most of the cases undergo resolution, 1% can undergo fulminant hepatitis, and some of them can go into either a carrier state, chronicity. Chronicity may be a persistent type, it may be an active type, and then of course in the long run it may enter into cirrhosis, may cause malignancy, and may also be associated with other extrahepatic diseases like polyarthritis nodosa and glomerulonephritis. So this is one thing which you should remember. I hope all of you have been vaccinated with hepatitis B virus. The thing is, everybody is very scared of HIV, but HIV is actually a very easy virus to kill. HIV is a very vulnerable virus, and it can be easily killed with our bleaching powder and all that. But hepatitis B is a very hardy virus. So in the lab tables, if we don't clean it, at hours in microbiology, if they don't clean, then it may live in that table for a long time because it can withstand extremes of temperature, humidity. Okay, and it can spread by contact with body secretions, and all of these, which I think you're reading. So I won't read out all of these, but you have to remember these are all the risk factors for transmission of HBV. And vertical transmission from mother to baby can also happen. Okay, so this is a picture which I'll be sending you as a pictorial quiz. This is the hepatitis B virus. It's a very schematic diagram. It's not at all like this. You will learn in microbiology much better about the structure of hepatitis B virus. But here we just want to tell you that these are the way they diagnose the infection with hepatitis B. So the first thing is, this is the surface antigen. So they test for HBsAg in microbiology. Anybody who's undergoing any type of surgery, major surgeries, will have to undergo hepatitis B testing. Anybody who's donating blood will have to undergo hepatitis B testing. Okay, the blood will go through hepatitis B, hepatitis C testing. Okay, because all these are the ones which are transmitted through the blood. So first here on the surface is the HBsAg. If this is positive, it indicates infection. And sometimes you have to test for the hepatitis core antigen. Okay, that means within the surface there's a core antigen, and at this level of the core antigen there is also hepatitis B E antigen. Okay, so both of these indicate infectivity, and at the core of it there is a DNA polymerase. So all these questions are more in microbiology, the size of the virion and all that. And this is also known as a Dane particle. I'll put in the quiz why it is named a Dane particle. This is also known as Australia antigen. Okay, it was first discovered in the aborigines of the Australia. Okay, so this is just to show you the detection of the titers of hepatitis B. Surface antigen is the one which can first be detected, but it comes down and you cannot detect it after 24 weeks. But the antibody starts coming, and the antibody to the core antigen is the one which can be there for a long time. So we can test antibodies. If you have antibodies, it means you had the infection at some point of time. IgM antibodies is the first thing to increase, and then it gets replaced with IgG antibody. So you can see that this red line is actually the IgM antibody to the core antigen, and you can see that it falls. Okay, but this green one is probably the IgG component of the antibody of the core antigen. This is the one which is persistent. Okay, so this is the way of serological diagnosis, in which you can test for the surface antigen, the E antigen, the HBA DNA, DNA polymerase. All of them signify active viral replication, and the immunoglobulin IgG will not rise until the acute disease is over. I hope you noticed in this that this is the HBsAg. As long as the antigen is positive, okay, the antibody will not be there, and there's a gap here, and then the antibody to the HBsAg will start increasing. That is what they mean here, that the IgG anti-HBs does not rise until the acute disease is over. So if HBe antigen persists, it means that the virus is replicating and the infectivity is high and there is progression of the disease. If you have antibody to HBe, it means disease is on its wane. IgM is an antibody which is at the acute phase. Okay. If serum transaminases is also increased along with the IgM, it indicates that there is hepatocyte destruction. IgG, anti-core HB, with decline of IgM can happen. That should happen along the way. And the basis of this antibody to HBs, this is the basis for current vaccination strategies, is to look for the antibodies. Like supposing you have taken a hepatitis B virus, vaccine. Okay, you know very well that one dose is not enough. You have to get booster doses. And why do they look for the booster doses? It's because you have to, supposing we want to check whether we are immune to hepatitis B, we have to look for the antibodies. So I have received the vaccination years back. Now if I am supposed to receive vaccination again, they will measure my antibodies to HBs. If my antibody level to HBs is high, they will say you do not need a vaccination, because vaccination is basically if the antibodies are on the waning side or they are reduced, then you need a repeat vaccination. That is the importance of testing for antibodies. So now these are also questions which we ask you a short answer question. What is a carrier state in HBsAg? Carrier state is defined as the presence of HBsAg in the serum for 6 months. Okay, so this is a short answer question. And then this is also a question, how HBV virus causes hepatocellular carcinoma. So this is because of a HBx, a protein of the X region. This is necessary for the viral replication. HBx can play a role in deregulation of hepatocyte replication and development of hepatocellular carcinoma in HBV-infected patients. Okay. So prevention of hepatitis B is by screening of all donor blood, organ and tissues, and also by vaccination. Now coming to the next virus, which is very, very important, and this is a very dangerous virus, much more dangerous than B, because it can go into chronicity very, very high. Most of the cases go into chronicity, unlike hepatitis B. Okay, so this is the most common cause of chronic bloodborne infection. And there are so many risk factors. These risk factors are the same actually even for hepatitis B. Okay, they are common. Like everything is based on parenteral risk factors. I think you can read this much faster, so I'm not going to read it. You have to remember that 20% can progress to chronic disease and cirrhosis. But this is one thing I want to point out. You remember that hepatitis A, I said 1% of cases can go into fulminant hepatitis. Hepatitis B also 1% can go into fulminant hepatitis, but hepatitis C is not known to really cause fulminant hepatitis. Very, very rare cases have been there. Most of the hepatitis C virus goes into chronicity, not fulminant hepatitis. Okay, so remember that. You might get an MCQ, which of these viruses rarely goes into fulminant hepatitis, and they'll give you A, B, C, D. Your answer should be C. Okay. Pathogenicity, you please read up these pathogeneses. When you read it up yourself, it is actually slowly you can read up, it is much better. So the thing is, you know that hepatitis B has got a vaccine, right? But this hepatitis C is quite unstable. So when we say a virus is unstable, we mean to say that it can have multiple genotypes and subtypes. So just like now, you know, COVID is happening, coronavirus is happening, and so many people are discussing about vaccines, and this vaccine is for this strain, this strain. Why? Because the virus is adapting itself and mutating itself and forming multiple mutants. So it becomes absolutely impossible for one vaccine to solve all the problems. It keeps on multiplying, and it's difficult to keep up with the virus, to know what type of strain, how to develop a vaccine against that strain. Okay, so these kind of viruses, what is written here is it seriously hampers the effort to develop a vaccine against hepatitis C virus. Okay, so these are points which you have to remember about hepatitis C. It's a poor fidelity. It is absolutely unstable. Unstable means that it gives rise to multiple genotypes and subtypes. The E2 protein is the target for many antibodies, but it is also the most variable region. Okay, so because of these, there are serious efforts have been made, but it's not been successful. And elevated titers of anti-HCV immunoglobulins occurring after an infection does not actually confer effective immunity. So this is also one reason. Just like you know about, I'll give you an example again because it's a happening thing right now. You know about COVID people. We have received 2 doses of vaccine, but it doesn't really protect us from the disease. I hope you understand that, okay? So it's the same thing here. Having antibodies against HCV does not confer effective immunity. Why? It's because HCV keeps changing. So the vaccine which you're receiving might be for some mutant strains, but the infection which you're getting is HCV with a different mutant strain. So the vaccine which you have received, the antibodies which your body has produced, will not necessarily protect you against the new mutant strain. Okay, so that you have to understand about HCV. So persistent infection and chronic hepatitis are the hallmarks of HCV infection. So serological diagnosis, HCV RNA is detectable at 1 to 2 weeks. Antibodies can also emerge after 3 weeks. In chronic HCV infection, there can be circulating HCV RNA. In symptoms of chronic hepatitis, we have to test for HCV RNA to assess the viral application and to confirm the diagnosis. So in HCV, if you have to test the blood for LFT, this is important. Episodic elevations in serum aminotransferases with intervening normal or near normal periods. This is typically what you find in LFT. You may find suddenly his normal, and after 1 week you test, suddenly his aminotransferase is very high. Okay, so that is something which you have to remember. So coming to hepatitis D virus, this is a very unique RNA virus. Okay, and it is defective in replication. It is not independent. It cannot replicate on its own. It causes infection only when it is encapsulated by HBs antigen. So although taxonomically distinct from HBV, HDV is absolutely dependent on the genetic information provided by HBV for multiplication, and it causes hepatitis only in the presence of HBV. Okay? So this is also known as a delta virus. So this delta hepatitis, look at this flowchart, it's quite easy to understand. If at the same time you're getting infection with HBV virus and delta virus, hepatitis delta virus, at the same time, that means the co-infection. Okay? But at the same time, the healthy individual is infected. You can see that the fulminant hepatitis, had it been only hepatitis B alone, it would have been 1% going into fulminant. But because the HDV is, friendly with HBV, it increases the fulminant hepatitis to 3 to 4%. And fulminant hepatitis causes death. So this fulminant hepatitis can lead to death, that I have told you. 90% can still recover with immunity. So even in HBV alone, 90% can recover. Okay. Rarely, it can cause chronic hepatitis and which can lead to cirrhosis. Now you look at superinfection. Superinfection means that a person already is infected with HBV virus and he has become a carrier. Okay. So the definition of carrier is that you can still detect HBV, surface antigen 6 months after the infection, right? So if the patient is a HBV carrier and then he gets infected with human hepatitis delta virus, that is known as a superinfection. And look at the percentages here. In a superinfection, the fulminant hepatitis increases significantly from 3% to 7 to 10%. Acute severe disease, 10 to 15% only. But look at the chronicity. Here, rarely, both of them, co-infection, chronicity is very rare. It can go to chronicity, it can cause cirrhosis, but it's rare. But here 80% can go into chronicity and cirrhosis. So this is also a question for you. It's a short answer question that superinfection is the one which causes most of the cases to go into chronicity and cirrhosis. Okay? So serologic diagnosis, HDV, RNA, you can detect that. And the antibody, the IgM, but like I said, IgM is the first antibody to appear, but it is also short-lived, and it has the IgG antibody has to take over. That is, everything in immunology is like that, okay? But IgM anti-HDV is the most reliable indicator of recent HDV exposure, but it is short-lived, like I said. Okay, so you remember this, that it is the most reliable indicator. Acute co-infection by HDV and HBV is best indicated by detection of IgM against both, denoting new infection with hepatitis B. With chronic delta hepatitis arising from HDV superinfection, HBsAg is present in the serum. I told you that a superinfection is mostly in hepatitis B virus carriers. That means they will have this in the serum for more than 6 months. Okay, so superinfection happens in the carrier HBV patients, and IgM anti-HDV can persist for months or longer. Then, and most of these cases will require most of these cases, because it's a systemic infection, even if liver transplant is there, the transplanted liver may again get infected by the same viruses. Then coming to hepatitis E virus, this is again fecal-oral, it's a waterborne infection, it's self-limiting, usually in young to middle-aged adults, and it accounts for over 50% of the sporadic acute hepatitis in India. The thing which you have to remember here, which can come as an objective question, which can come as MCQ, is that the feature of hepatitis E infection is that there is a high mortality rate among pregnant women, up to 20%. Meaning if a pregnant woman gets infected with hepatitis E, there is a 1 in 5 chance that it might be lethal. Okay? So this, you'll find rising serum aminotransferases, clinical disease, elevated IgM, anti-HBV are virtually simultaneous. All of them happen at the same time. You can detect at the same time. Okay? So that's the only thing. We do not ask you short notes on hepatitis E, all these, but hepatitis B and hepatitis C are the ones in which, if we do ask you questions in pathology, it will be related to B and C. Analytical question can be related to hepatitis A. Okay, but E we don't ask, even G we don't ask. In fact, hepatitis G virus is a misnomer. Okay, so remember the first slide I said hepatotropic viruses, and I did not mention G in that. Okay, hepatotropic viruses are A, B, C, D, E. Okay, so here HGV is not hepatotropic, but and it does not cause elevations in serum aminotransferases. That's why it is a misnomer. Okay, so here this HGV is again transmitted parenterally, and it commonly co-infects patients with HIV. But curiously, this dual infection is somewhat protective against HIV disease. So there's not much study being done on hepatitis G. This is just for your general knowledge. Just remember that it is a misnomer because it does not cause elevations in aminotransferases. So the clinical pathologic syndromes which can happen with hepatitis virus is, it may be acute asymptomatic infection only and the patient recovers, but there is serologic evidence when you test the serum, because there are so many, right, who are absolutely asymptomatic, and when you test you find that, oh my goodness, he's HBV positive or he's HCV positive. Why do we detect all the blood donors? Why do we test the blood of all the blood donors? It's because many patients who are asymptomatic for HBV, HCV come as blood donors, and then only discover that they are HBV or HCV positive. Okay? So there are these asymptomatic infection. So that is one, acute asymptomatic. Another is acute symptomatic hepatitis. So we were going through the clinical pathologic syndromes. So like I told you, I explained about the asymptomatic infection. There can be those who are symptomatic with recovery. They can be anecteric, meaning they are not jaundiced, or they may be icteric, meaning they might be jaundiced. And those which have chronic hepatitis, some of them with cirrhosis or some of them without progression into cirrhosis. And fulminant hepatitis is basically massive to massive hepatic necrosis. And like I have put here, A, B, and D can undergo into fulminant hepatitis. And every time when there is hepatitis, we have to rule out whether the hepatitis could be caused because of some drugs or toxins. Like paracetamol is a very, very safe drug. But if somebody takes a lot of paracetamol altogether, it may go into a hepatic necrosis, submassive hepatic necrosis. Okay, so that's what I mean by saying rule out infections, drugs, and toxins. So here in symptomatic, there are 4 phases in hepatitis. There's an incubation period followed by pre-icteric phase in which there is a lot of constitutional symptoms, meaning nausea, loss of appetite, vomiting, fever. All these are constitutional symptoms. And enlarged tender liver might be there. Then a symptomatic icteric phase may be there, in which you can detect by the LFT and convalescence. So chronic hepatitis, this is also a short answer question which may be asked to you. What is how is chronic hepatitis defined, or what is the definition of chronic hepatitis? So you have to remember these words, that chronic hepatitis is first of all symptomatic. Biochemical and serologic evidence should be there of continuing or relapsing hepatic disease for more than 6 months. Remember, this 6 months is just like the carrier state. Chronic hepatitis also is 6 months. And what is more important about chronic hepatitis is that it should have been histologically documented inflammation and necrosis. That means liver biopsy should have been done, and we would have seen the slide and noted down inflammation, necrosis. Then only you can label a person as chronic hepatitis. Okay, so the thing is, chronic hepatitis there is a likelihood of it progressing into cirrhosis. Okay, and individuals with impaired immunity are particularly likely to become HBV carriers, and the age at the time of infection is the best determinant of chronicity. So this is the morphology of acute and chronic hepatitis. In acute hepatitis, if you see this, this is the portal tract, okay? And you get a lot of inflammation within the portal tract, okay? And you notice actually, if they had given a normal here, the portal tract is a very well-defined round thing. But here you can see that the inflammation is going beyond. This is known as a limiting plate, okay? This area is known as the limiting plate, the area where the hepatocyte and the portal tract just meet, that is known as limiting plate. So once the inflammatory cells progress beyond this limiting plate, like you can see here, this is the hepatocyte, this is a hepatocyte also. But you can see that this inflammation is extending beyond the limiting plate and actually surrounding a hepatocyte, causing necrosis of the hepatocyte. This is known as interphase hepatitis, in which you have the inflammatory cells crossing over the limiting plate into the hepatocytes and destroying the hepatocytes, causing periportal necrosis. That is known as interphase hepatitis. And if you look at the hepatocytes, these are normal hepatocytes. But then the most common, this is also an MCQ question, the most common form of degeneration is ballooning degeneration. What do we mean by ballooning degeneration? Basically, it means that the hepatocyte is enlarged. All these are ballooning degeneration. It is enlarged and it has some kind of, the color it takes is much lighter. I'll show you pictures. Okay. And then, of course, there may be reversible damage of the hepatocytes, fatty change in hepatitis C especially. Some of the hepatocytes can die because of apoptosis, okay? And of course, in the long run, there can be cholestasis. And inflammatory cells in acute hepatitis, it may be restricted to the portal tracts. In chronic hepatitis, the macrophage aggregates can also come in. And here you can see macrophage aggregates in chronic and also in acute. And here, the most important difference between acute and chronic is that the inflammatory cells, of course, will be more of neutrophils. In the acute, in chronic hepatitis, it's more of lymphocytes. There can be lymphoid aggregates formed. And very important is that this inflammation, when it spills over, anything about inflammation, the last healing process of inflammation is always fibrosis, right? So here you can see that the inflammation at this, supposing it has spilled over and reached the central vein, so this is the inflammation-induced fibrosis. So from the portal tract to the central vein, if there is necrosis of the hepatocytes, that becomes replaced by fibrosis. So bridging meaning a bridge from portal tract to the central vein, that's a bridging necrosis, which becomes replaced in the long run by bridging fibrosis. So these are the two main important differences between acute and chronic hepatitis. The others are the lymphoid aggregate. If there is hepatitis B infection, ground glass cells will be there. I'll show you a picture. Hepatitis C, fatty change. Okay? So these are the changes which you get in acute hepatitis. You can go through it later. This is a picture showing you, these are the hepatocytes. This is the portal tract. This is a bile duct tube. Okay? So each portal tract, usually you see only one bile duct tube. But when there is a lot of inflammation in the portal tract, the bile duct tube starts to react and it starts to become tortuous. Okay? So when it starts to become tortuous, when you cut a section, you might actually get multiple bile. Bile ducts. Can you see this? This is 1, this is 2, this is 3, this is 4. In one portal tract, you may get multiple sections of a bile duct, and that is known as bile ductular reaction. Okay? And you're seeing here there's a lot of inflammation. This is the capillaries, this is the vein. And what's important here to notice is these are the hepatocytes, and you can see that this is the hepatocyte here. That means this is the limiting plate which has been damaged by the inflammation, and the inflammation has come in, crossed over to the hepatocytes. So you can see that this hepatocyte is surrounded by these inflammatory cells. This is known as interface hepatitis, and this is known as periportal necrosis. Okay? And this, can anybody see what this shows?
Coilocytic change.
Coilocytic change is actually seen in the cervix only. We don't say coilocytic change in the hepatocyte. From whatever list which I have shown you.
Ballooning.
Okay. Very good. Yes. Ballooning degeneration of the hepatocytes. Okay, this is ballooning degeneration of the hepatocytes. Now, another thing which can come as a question for you is the features of chronic hepatitis, or they may specifically ask features of hepatitis C virus, because hepatitis C virus has specific features. Okay, so inflammation is common to both. Hepatocyte necrosis and architectural loss happens only when chronicity sets in. Architecture is lost only when chronicity set in. Now, hepatitis C virus, the things which are characteristic. Okay, the question might come, what are the characteristic pathological features of hepatitis C virus? That will be lymphoid aggregates, bile duct reactive changes, and macrovascular steatosis. These are the three things which you should answer in the question if there is, what is the characteristic feature of hepatitis C virus on biopsy or pathological changes. Interface hepatitis, bridging necrosis, and the hallmark of irreversible damage is always fibrosis. Okay? Then cirrhosis, post-necrotic, can cause regenerative nodules. This I'll show you a picture. Clinical course, of course, will be progressive. Cirrhosis can be there, liver failure can set in, hepatic encephalopathy can set in, and finally, hepatocellular carcinoma. Can anybody identify this stain? What it is trying to stain and what is the name of the stain? Do you know? How is it that the hepatocytes are maintained in a cord-like fashion like this? The architecture is very beautifully in a cord-like fashion. It's because of the... Remember in the previous class I had told you that the connective tissue framework of the liver, if it is damaged, liver regeneration will just cause lumps of hepatocytes sitting on top of the other, forming a nodule. But if the connective tissue framework is not damaged, then the regeneration will happen exactly as if the normal liver is back, because the connective tissue framework is the one which provides the architecture. Okay, so what is this black staining here? What does it stain?
Elastin.
No, not mastane. I'm not asking that. Elastin. Okay, very good. So elastin is also a stain for connective tissue. However, in the liver, This is not elastin. Elastin is a connective tissue stain, but here I want the name of another connective tissue stain. Elastin is mostly in blood vessels, okay? Because the arteries contain the elastic lamina. So in that case, we use elastin stain. But in the liver, we do not use elastin stain. We use reticulin stain. These are reticulin fibers. Okay. So the connective tissue framework in the liver is detected by doing two stains. One is a reticulin stain, and another one is the one which, remember I showed you in the last class, blue one, Masson's Masson's trichrome stain.
Mesentrichrome.
Very good, yeah. So reticulin and Masson's trichrome. Okay. So this stain we do when we get a liver biopsy, we do the stain because it helps us to detect this. Can you see that this is also a reticulin stain, but can you see here that there is a lot of black? Basically, if you just imagine if these hepatocytes undergo necrosis, okay, they undergo necrosis, these hepatocytes undergo necrosis, the reticulin framework will collapse and it will form a compressed mass of black. Okay, so this is what a pathology uses. When we use a reticulin stain, we are looking for evidence of hepatocyte necrosis, which may be difficult for us to see on HNE only. So we look for this reticulin fibers, dense collection of reticulin fibers, meaning that the hepatocytes in between have collapsed or necrosed. That's why the reticulin framework is collapsed here. Okay. Now, this just goes to show that these are hepatocytes again. These are known as ground glass hepatocytes, and they indicate that there are viral inclusions of hepatitis B, which can be detected by immunohistochemistry. You can see this brown thing. It's detected by immunohistochemistry as hepatitis B, and it confirms, if you take a liver biopsy and we do this, we confirm the infection as hepatitis B. And hepatitis C, lymphoid aggregate. These are lymphoid aggregate. This is the hepatocytes, and you can see that this collection of lymphocytes, and there are scattered lymphocytes all through trying to damage the hepatocytes. Okay, it's spreading out everywhere. So you can see that there's a collection of hepatocytes here trying to regenerate. So this is exactly what happens when there is necrosis and then fibrosis sets in, and this is what happens to the liver. You can see that the surface of the liver is now completely nodular, meaning that there is necrosis. The whole progression of this pathology is that the hepatocytes become necrotic, a line of hepatocytes become necrotic. That necrosis is replaced by fibrosis, and once fibrosis sets in, so if this area gets fibrotic and there are some hepatocytes which still have the capacity to regenerate, they will regenerate and form a nodule because they are compressed by fibrosis all over. So that is exactly what you see grossly. You can see these are nodules and there are depressed areas in between, right? So these areas are all fibrotic areas, and these are the regenerating nodules of hepatocytes. Most of the regenerating nodules will not have the architecture of liver, like a lobule has a portal tract and a central vein. Regenerating nodules will look like this. These are the hepatocytes, but somehow they have lost the lobular architecture. And this blue, this is what stain now?
Masson's trichrome.
Masson's trichrome stain, which is a stain for collagen, which confirms that there is cirrhosis in the liver. Okay, so why I'm asking you repeatedly is because these are short answer questions. We ask you what are the stains used in liver biopsy. Reticulin stain is one, which detects the integrity of the connective tissue framework of the liver. Masson's trichrome is a stain for collagen, which detects, which confirms cirrhosis of the liver. Okay, so here you can see these are regenerating nodules, and this is the bands of fibrosis, and this confirms that cirrhosis is set in microscopically. Grossly, of course, you will see this. And based on the size of the nodules, we will again look whether it's a micronodular or a macronodular cirrhosis that we will discuss in the cirrhosis class. Fulminant hepatitis is when the hepatic insufficiency progresses from onset of symptom to hepatic encephalopathy within 2 to 3 weeks. This is a very dangerous condition. I have lost my cousin brother and cousin sister because of fulminant hepatic failure. They were diagnosed initially with hepatitis. They were looking okay, as if they're going to improve, and then they are brought to the hospital in hepatic encephalopathy. And it is so late that nothing can be done about it because the liver in fulminant hepatic failure undergoes complete necrosis, and there is nothing which can be done about it. Necrosis, as you know, is an irreversible cell injury. So nothing can reverse that, and the only thing is it becomes lethal. Okay. So there are so many causes of fulminant hepatitis apart from hepatitis viruses, drugs, chemical toxicity. There are some this acetaminophen, meaning paracetamol, isoniazid, all this. Okay. So all these are causes of fulminant hepatitis. There's something known as a subfulminant hepatitis, meaning that lesser percentage of the liver is necrotic, and that usually takes some more time, within 2-3 months, whereas fulminant hepatitis is within 3 weeks. Okay, so clinically you will have all the signs of liver failure. The morphology, entire liver will be involved, or only random IVs may be seen. Shrunken liver, and this is one important thing because the hepatocytes are just necrotic and they shrivel up, so the capsule over the liver will become wrinkled. Okay, this is a feature of something which happened, which is an acute process. Okay, so there is destruction of hepatocytes, and the reticulin framework becomes all collapsed, inflammation is mild. Patient survival for more than a week permits regenerative activity. So that is one thing. If you can, in subfulminant, you still have the time actually to try to make the patient survive for at least 1 week to 10 days so that his own liver regenerates. Okay, so in subfulminant hepatitis, you can still have the ability to bring the patient back, but in fulminant, it is extremely lethal. Okay, so this is what I mean when I say that the capsule is wrinkled. You can see the surface here, there is wrinkling of the capsule. Okay, and this is the fulminant hepatitis. The hepatocyte is replaced by inflammatory cells, and finally this will be replaced by necrosis. Okay, so this is the long-term sequelae of chronic hepatitis, which is the B, C, and the D. So this is the normal liver, how it looks. In chronic hepatitis, you have macrovesicular steatosis. This is all Mason's trichrome, okay? So basically, you can see the stain here. In normal liver, it's staining only around the portal tracts and around the central vein, and this pink thing is all hepatocyte. In chronic hepatitis, you can see that the blue has become much more. That means there's so much more collagen where it should not be. The hepatocytes are filled with fat. Some normal hepatocytes are there here and there, but there is more of blue. And in cirrhosis, it's completely almost, there is basically a lot of blue, and in between are the regenerating nodules. Okay. And finally, when there is regenerating nodules, there is no architecture at all. There is bound to, just like dysplasia goes to carcinoma, here cirrhosis, there could be something wrong depending on the primary pathology like hepatitis B or hepatitis C leading to cirrhosis. There can be development of hepatocellular carcinoma. Okay? So, I know that all of you have that atlas of pathology, the skill domains, right? You have it in a soft copy. So in that, we have made some 3 linkers of the chapter of liver. So I want you to go through those. We have already given the answers also in that. Please go through that skill domain atlas. Okay, and this is one of the linkers, which is I think it's easy for you to give the diagnosis in this case. I've given a very typical history. Okay, so and this gives you an inkling of how to use the LFT also. Okay, so please go through that skill domains and the linkers associated with it. So this is the end of my class for today.